my name is Adriana Gree, and today my group mates and I will be presenting our community project regarding Duchenne muscular dystrophy in clinical dentistry. Duchenne muscular dystrophy is an X-linked genetic disorder known to cause some of the most severe symptoms within the category of muscular dystrophy. In our presentation today, we'll be addressing the question of how DMD affects standard care in dentistry. Throughout our presentation, we will be discussing some background on Duchenne muscular dystrophy, some background on dentistry, as well as how dental care is affected when caring for a patient with Duchenne. We will also be discussing possible barriers and treatments for patients. And finally, we'll be going over a case study and future directions to improve the quality of dental care for patients with Duchenne muscular dystrophy. So as previously mentioned, Duchenne muscular dystrophy is an X-linked recessive disorder which causes a mutation in the DMD gene. The DMD gene is one of the largest genes in humans, and because of this, it can experience many mutations. Mutations to the gene can occur randomly or hereditarily via genes passed down from the mother's X chromosome. There are a variety of mutation types, including large or small exon deletions, large or small exon duplications, missense mutations, nonsense mutations, splice site mutations, intronic mutations, etc. However, regardless of the origin or type, most of these mutations result in the inability to produce well-functioning dystrophin, which is the protein produced by the DMD gene. The role of dystrophin is to stabilize and protect the sarcolemmal membrane and the different proteins which interact with it. Dystrophin links the transmembrane components and the intracellular components of the dystrophin glycoprotein complex to ensure that all proteins are localized in their proper place. Dystrophin protects the sarcolemma from contraction-induced injury by promoting flexibility and elasticity. In DMD, dystrophin can be entirely absent, missing a large chunk, or present but non-functional. Regardless, without well-functioning dystrophin, muscle is much more susceptible to contractile-induced damage. There is gradual muscle degradation, which is followed by the loss of a variety of body movements and organ functioning, including walking, breathing, lifting, etc. DMD is most common with boys as it is an X-linked disorder, and it usually appears around the ages of 2 to 6. Studies have shown that DMD affects roughly 1 in 3,500 males worldwide and is one of the most common as well as one of the most severe forms of congenital myopathy. Finally, the mean survival rate of an individual living with DMD is roughly 29 years. Starting around the ages 2 to 6, individuals with DMD begin to develop progressive muscle atrophy. This leads to muscle weakness, pain, and stiffness. They can experience a loss of strength and flexibility in the hips, thighs, and pelvis. Children can typically present with calf muscle hypertrophy, which is the enlargement of the calf muscle weakness, scoliosis, delayed or altered walking, delayed cognitive skills, etc. Once they hit their teens, roughly around the age 13, most will lose ambulation and require a personalized wheelchair. As teenagers, they begin to experience loss of strength in their upper extremities, lower legs, and the trunk. They may also develop cardiac complications, including dilated cardiomyopathy, as well as respiratory complications, including respiratory muscle fatigue, trouble coughing, and collapsed airways. Next, we will be reviewing some common dental structures. Firstly, the jaw and the mouth and the teeth. The main types of teeth are the incisors, canines, premolars, and molars. Next, your dental arch, which is the structure which contains your teeth and your gums, is responsible for supporting a healthy shape of the mouth to house the teeth and maintain a proper bite. There are many muscles involved in the mouth which assist in chewing, swallowing, and other functions. Masticatory muscles include the temporalis, masseter, medial pterygoid, and lateral pterygoid muscles. The perioral region includes the lips, oral commissure, nasolabial folds, marionette lines, and chin. All the muscles within these regions should be well functional enough to chew and swallow, etc. Finally, a very important structure in the mouth is the tongue. The tongue is responsible for proper chewing, swallowing, breathing, and even speech. It is a muscular and a digestive organ made of mostly muscles. It should present as some sort of shade of pink, and the average size is roughly 3 inches long and 2.52 inches wide. In the next slide, we'll be discussing how DMD affects dental hygiene and dental health. Many of the muscles involved in the mouth, including the masticatory and perioral muscles, weaken. Individuals with DMD may also experience oropharyngeal and hypopharyngeal weakness. They can present with macroglossia, which is the enlargement of the tongue. And they may also have broad and shallow dental arches, which changes the structure of the teeth. Some patients may also have oral candidiasis, which is an infection of the oral cavity and typically presents as whiteness on the tongue or whiteness or bumps on the cheeks. Many may also have anterior and or posterior open bites, and some may have malocclusion. Because of the many symptoms discussed previously, individuals with DMD may experience many individual challenges when it comes to dental health and hygiene. Most can experience difficulty chewing and swallowing due to weakened muscles. Muscle weakness, not only in the mouth, but also in the upper extremities, make it much more difficult to perform daily hygiene tasks such as brushing their teeth or flossing. Many may experience xerostomia, which is extreme dry mouth, which can be particularly bothersome, especially when it is experienced simultaneously with mouth breathing. Finally, most individuals with DMD are unable to receive anesthesia due to cardiac issues, and this will be discussed further later in the presentation. Thank you.
Hi everyone, my name is Rania and I will be talking a little bit about the barriers to accessing dental care for these patients, as well as some treatments that exist out there. So getting into the issue of barriers to accessing dental care, these are all issues that have been reported by patients with special healthcare needs themselves. And so as you can see, some of the issues are that providers just aren't willing to treat them. There's a very long wait time for getting dental care, and that's combined with already a very high cost. And they have to take into consideration that the office itself has to be physically accessible for them. And once they get an appointment, they have to often travel very far from home to get seen. And so in 2017, the Journal of the California Dental Association, they conducted a study asking all patients, what are some issues that you have run into in terms of getting access to dental care? And it turns out that these issues are very intertwined with one another. And due to the scarcity of providers that are willing to take on patients with special healthcare needs, there are very few options for these patients. So they're forced to wait very long times. And because they're seeking out a very small group of very specialized dental providers, that just ramps up the cost for them. And that's on top of the things that they already have to pay for in order to maintain their condition, like cardiology appointments, pulmonology appointments, corticosteroid treatment, etc. And so these patients can go very long times without having their issues addressed. And so getting a little bit more into the issue of provider unwillingness to treat, this was actually in the 2017 study that was mentioned before, this was actually the highest ranking barrier to accessing dental care as compared to measures like transportation, cost, the fear of going to the dentist, long wait times. And so why is this true? And it turns out that this issue of dealing with patients with special healthcare needs is not very emphasized during dental training. So these dentists are getting trained and going out into the world, but mostly dealing with patients that don't have very complex special healthcare needs. And then this is already combined with the issue of poor insurance reimbursement. So the providers would not be getting paid enough in their eyes to take on such complex patients that they're not comfortable or confident in treating. And there's also this issue of disproportionate access between adults and children with special healthcare needs. Adults generally have a harder time for finding an appointment or a dentist because there are pediatric dentists out there that are specialized in treating children, and they're willing to take on children with special healthcare needs, but an equivalent doesn't really exist for adults. And so this is also combined with the fact that adults with DMD, the progression of their disease and their condition is just a lot more compared to children. So they have cardiomyopathy and respiratory issues that they have to take into consideration. And so it's scarier for providers to take on these patients. And then the third thing that we have to consider is issues with insurance. And so in California, there exists Medi-Cal, which is a state healthcare plan for people of lower socioeconomic status. The problem is that according to calmatters.org, many dentists in California do not take Medi-Cal. And so this leaves patients of lower socioeconomic status without a provider that is willing to take on their insurance. And so again, it becomes a matter of low reimbursement rates by the insurance that de-incentivizes treating this population of patients. And so if they want to get care, often it has to come out of pocket for them. And again, this is something that's already piled on top of the many healthcare appointments that patients with DMD need in order to just maintain basic health. Okay, so this is just some further consideration that we can think about for patients with DMD. So say they have been waiting months and months on end to get the appointment. It's the day of the appointment now. What sort of things do we have to consider now? Well, the provider, the primary caregiver for the patient, they often have to take extended time off in order to make special planning trips for getting to the dental office. And again, because there is such a scarcity of providers, chances are that most patients, they have to travel very far. Oftentimes it's over an hour to get to the appointment. And for some patients, it may mean that they have to travel hours on end. And so this would mean that it's probably best for them to stay at a hotel nearby instead of driving to the dental office, back home, and then again. And this is very common if the provider recommends that the procedure be done over the course of several days. And so sometimes this is done, for example, to avoid patient fatigue, especially. And then another consideration is paying for surgical fees. And so procedures that require the patient to undergo general anesthesia, they often end up being more expensive because they require a bigger team. And why might this be? Well, take a look at this anesthesia machine. As we can see, it's very complicated. It has a lot going on. For example, it has a vaporizer, which takes the liquid anesthetic and vaporizes it so the patient can inhale it. It has oxygen monitoring and it has a heads up display, it has a lot going on. And so this machine requires an anesthesiologist, which is a medical doctor that's specialized in using, for example, these machines to monitor the patient's vitals as they are undergoing a procedure. And so to have an anesthesiologist have to be part of the team, that means having to pay a doctor. And so the cost of the procedure can rise very quickly for these patients. And so to get into the issue of cardiomyopathy, which is again something that's very commonly seen for patients with DMD in their advanced stages of their disease, is that it makes them at very high risk for developing complications and even dying from any procedure that involves them undergoing anesthesia. And so anesthesia, just as a background, has a depressant effect combined with low myocardial function. So both of these things can lead to something called hemodynamic instability. And that is when the flow of blood throughout the body is affected. And so patients with dilated cardiomyopathy, they already have suboptimal blood that is pumping through their body because their left ventricular wall is often hypertrophied. And so not enough blood is getting to the body already, but this combined with the effects of anesthesia can be particularly dangerous for their body. And so this often means that there is the need for very invasive monitoring to check that the patient is not undergoing hemodynamic instability. And so the anesthesiologist can monitor the patient and the amount of medication that they're receiving throughout the procedure. And so why would it be risky for patients to have hemodynamic instability? Well, some of the issues are tachycardia, which can result from low cardiac output. The loss of ions can result from arrhythmias. Increased afterload, that can also worsen cardiac output. And the changes in the preload in the presence of elevated left ventricular and diastolic pressure. All of these things are very complicated things that the dentist and the anesthesiologist and the nurses have to look out for in order to potentially stop the procedure in time to save a patient's life if they are not tolerating it well. And so an alternative that has been proposed by some studies is the use of intravenous conscious sedation. And this is a combination of sedatives and anesthetics that can relax the patient and block pain during a dental procedure in this case. And the patient can stay awake. They can also fall asleep, but most of the time they're not able to speak throughout. So some of the pros to using the intravenous conscious sedation over the traditional anesthetic approach is that it gives the patients more of an opportunity to save their teeth. Their provider can come up with a creative solution to meet both their aesthetic wants and their medical needs. And often this is done over the course of a few days. Whereas typically, if you were to put a patient under anesthesia, you would just be removing the teeth instead of trying to save them. And then also this can be done in an outpatient setting. There's no need to go to a hospital, book an OR, or have an anesthesia machine, which is manned by an anesthesiologist. And then this approach also has quick recovery relatively. The patient wakes up as if they had just gone to sleep, and they may or may not remember the procedure. And then, of course, because there's no anesthesiologist needed, the cost of this approach is much lower. And then some of the issues that this approach would not solve is that we still need the patient to be cared for by a skilled, trained, and experienced dental professional and their team of nurses during the procedure. And then this also may not be the correct approach if a patient has really serious respiratory or cardiovascular limitations, in which all sorts of invasive procedures would put them at risk.
Hi, everyone. My name is Malia. All right, so I'm going to be going over the case study. So just to give a little bit of background information, the patient that we are looking at in this case study essentially wanted orthodontic treatment. So he wanted to get braces, and he's a 22-year-old patient with DMD and macroglossia, which is essentially just a large tongue. And just to give a little bit of background about his lifestyle, he does use an electric wheelchair and also relies on his caregiver to brush his teeth, just because he is unable to voluntarily lift his arms and have that range of mobility in order to brush his teeth himself. He basically wanted orthodontic treatment because he had a chief complaint of difficulty of chewing, which essentially was affecting his quality of life. And he didn't have any tooth decay or any periodontal disease. So in terms of oral hygiene, he was actually pretty good when he first came in for his orthodontic evaluation. So going into the clinical presentation, one of the things he presented with was an anterior open bite. In his particular cases, it was about 8 to 10 millimeters open. So normally when people bite, we should be able to touch our front teeth together. And if people do have an open bite, it often occurs because thumb sucking habits haven't stopped, or there's just other obstructing factors in the way. Because this patient did have a large tongue that ultimately was pushing his front teeth apart. And when we smile, we should also be able to feel our back teeth touching together. But this patient also had a posterior open bite, so his back molars were not touching at all. And that was a posterior open bite of about 0 to 12 millimeters. So that was another thing that his tongue was affecting. We also see that there's excessive buccal crown torque, which essentially just means rotation. And we can see by the teeth that are circled in green that the top of the tooth isn't quite facing directly underneath the teeth on the upper jaw. It's tilted outwards towards his cheek, which is going to affect the way that it feels when he closes his mouth and smiles. And there is also just a lot of generalized spacing, as we can see in the photo. The patient also has something called a class 2 molar occlusion. It's just a fancy way of saying he has a slight overbite. So we see from this graphic that basically the back teeth and the front teeth are slightly anterior in comparison to the bottom teeth. So normally people want to have a class 1 molar occlusion where the back teeth of the upper jaw are slightly posterior in comparison to the back teeth of the lower jaw. And then the overbite in the anterior teeth is not as pronounced, so that there is just very slight overlap of the upper teeth in front of the lower teeth. But the main concern that the patient came in with was the macroglossia, or the large tongue, and this ultimately was the root of a lot of the problems, as we talked about earlier. This was contributing to the anterior and posterior open bite, and it just makes it very difficult to be able to chew and eat and swallow with such a large tongue in the way. And this can also ultimately affect speech and even sleep. If the patient sleeps on his back, this is definitely a high risk for sleep apnea or obstructive sleep apnea. So in terms of the treatment planning, the dental team decided they were going to extract the third molars, also known as the wisdom teeth, and a supernumerary tooth that the patient had, which basically means an additional tooth outside of the normal 32 count of adult teeth. And they also wanted to reduce that tongue volume, so just making it easier for airway passages and also hopefully to reduce some of the occlusion issues, and close that anterior and posterior open bite so that it would be easier to chew food and just have daily function when it comes to speech as well. And also just for aesthetic purposes, being able to have a nicer smile, and increasing the incisor display, which essentially means the amount of incisor tooth that one is able to see when someone normally smiles. So the first phase of the orthodontic treatment started in June of 2009, and they extracted those third molars and also that additional supernumerary tooth. And there was also a glossectomy that was performed in order to reduce the tongue volume, and that was performed under general anesthesia, as shown in the photo. Now, one thing to consider that Verania did mention earlier is the risk of general anesthesia complications, especially for patients that have underlying conditions or comorbidities, especially in this case of the patient who has DMD. When we see in the photo that he does have a trach tube inserted, and that was actually not something that he had prior to any of this orthodontic treatment. And in the actual paper of the case study, it was unclear if this was inserted as a preventive measure, just in order to help mitigate risk and increase airway function efficiency, or if something actually did go wrong during the procedure and this was an emergent procedure that was done. So in the end, it is just extremely important to always consider the background and history and the medical needs of the patient, and be able to take that into account as treatment planning occurs, and also be fully transparent with the patient of any risks that do come up. So the second phase of treatment occurred in April 2010 after the patient had recovered from the glossectomy surgery. And at this point, there was a reassessment in the treatment plan because they saw that the anterior and posterior bite had actually closed significantly just spontaneously. So being able to reduce that tongue volume actually helped a lot in allowing the teeth to shift into a more natural position. And so we see in the photos how much that anterior and posterior bite has closed. Obviously, there is still some spacing, but it's gotten a lot better. One other thing to note was that the hygiene of the patient had actually worsened during this time, as indicated by the yellowing and the plaque that we see in those images. And we do know from the background that the patient does rely on the caregiver. So it is a possibility that the caregiver just wasn't as efficient as brushing teeth, but we also know that a patient who is recovering from surgery and already has more comorbidities is going to be more immunocompromised. So this definitely was a contributing factor in why the hygiene potentially could have worsened. That being said, the oral hygiene state was still not too concerning, that they were able to proceed with the orthodontic treatment. So we see in the images on the right that they began placing the brackets and putting a lot of rubber bands in order to fix a lot of that rotation that we talked about, and also just trying to fix the curvature of his teeth. We see in the bottom image that his bottom teeth don't make a nice curve, and it kind of comes more of an angular shape. So just being able to round that out was essentially the goal. So phase 3 of the treatment occurred in June of 2011, and we can see from these photos that there is significant improvement just even in comparison to phase 2. We see that the open anterior and posterior bites have been taken care of, and the teeth are very straight. The curvature of the smile is really nice, and here they're just doing the final adjustments. We still see we have one rubber band just to fix those last few degrees of rotation is probably something even just the dentist would notice. But this treatment essentially was done in about a year since the start time, which is really impressive, just even thinking about how our own orthodontic treatments might take so much longer than that. So all the more so to this dental team for being able to undertake this case, especially with a patient with an underlying medical condition. And we do see in the photo on the right, once he got his braces off, how his teeth look like. And so here we see a before and after of the patient's teeth. Obviously, a lot has changed, and this is really going to be helpful for just the patient's daily function in being able to eat and communicate. One thing to note is that the patient did have to wear Holly retainers, so those kind of metal and plastic retainers, in order to maintain just the position and the posture of his teeth, but overall it is a significant improvement and definitely something that I'm sure this patient was really happy with achieving. So going into the discussion, it's really important to note that just because patients specifically with DMD do have a decreased life expectancy does not negate the fact they still want a good quality of life. And so providers definitely need to be mindful of the needs of the patients. And they really have to consider the medical history and any comorbidities during the treatment planning, and really being able to make a tailored procedure so that what they want to do in terms of medical treatment is feasible with the patient that they have. For our particular patient in this case study, there were definitely a lot of respiratory concerns during the sedation, so that was something that they had to be mindful of. Another issue is that because the patient is wheelchair bound, specifically in an electrical wheelchair, it was difficult to do any kind of x-rays. And in the facility that the dentist worked, they were actually unable to do traditional x-rays or panoramics. So the patient had to be sent to a medical imaging facility in order to get that obtained. And just thinking that even though this patient was able to do that, it's not necessarily feasible for every patient with DMD, because not everyone is nearby an imaging facility, or they might not be able to get into a building regarding wheelchair access, or they might just not have the money or the means of being able to access those resources or have the transportation to do so. Another issue was just thinking about wheelchair accommodation. Not every dental space is able to be ramp accessible or even have large hallways or rooms that are able to fit a wheelchair. And for some clinics that even are able to accommodate a wheelchair in its space, this doesn't always mean that a patient is able to transfer from the wheelchair to the dental chair. And that was the case with the patient in this case study. They were not able to do wheelchair transfer. However, the electric wheelchair that this patient was in was also only able to tilt back by about 45 degrees, which is not ideal for the dental team. So the dental treatment was actually performed by the dentists who were standing or kind of bending into awkward positions in order to accommodate the patient. And it is great that they were able to do that, but not every provider is always willing to do that either. So one thing I really want to stress here is the emphasis on informed consent. Those who are more informed are actually more likely to want dental services. They are going to be less anxious, require fewer pain medications during and after the procedures, and will ultimately have more realistic expectations from their healthcare providers. And this will ultimately help affect the compliance during the procedure and also just following up with post-operative care. They'll have just better satisfaction with treatment and want to kind of even come back to the dental clinic. And so I just really want to stress the importance of patient-centered care, because it shows that it is possible to provide medical treatment to individuals with any medical conditions or comorbidities or special needs, because it ultimately does improve their well-being and quality of life. But providers have to be willing and understanding of the patient, and just being able to accommodate them and meet them where they're at. So this concludes our presentation on Duchenne muscular dystrophy and the intersection with dentistry. Thank you so much for listening.